How do we bridge the gap between research evidence and real-world palliative care practice? What can a case study from Kenya teach us about pain management relevant to Colombia? How does end-of-life care differ in rural India and urban Brazil? I'm Jane Bates, and I want to invite you into a global conversation about palliative care. Welcome to Palliative Care Matters, where healthcare practice meets evidence-based learning. This podcast is for anyone interested in palliative care across the globe. In each episode, we will hear stories from practitioners like you, followed by discussions that connect and inspire you in your daily work. So whether you're in a busy hospital in Lagos, a community clinic in Bangladesh, or a care home in Manchester, you have stories that can teach us all something valuable about compassionate, evidence-based care. Feel free to submit your cases, send us questions, and join this global learning community. Palliative care matters, because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts. Sunitha, great to speak to you this afternoon, and thank you very much for sharing this case, which looks like a really interesting one. Before we start, can I just ask you to introduce yourself and tell me a little bit about what you're doing?
Right. Okay, Jen. So I work as a consultant in palliative medicine in the UK currently. And before being consultant in the UK here, even though I trained in the UK, after being a consultant, I went to India and worked for a few years as a palliative medicine consultant in India. And then I've come back to the UK. So I sort of have an experience of maybe working in two different contexts and two different countries, I would say. And the case that we discussed today probably, highlights the difference.
Yeah. So no, it's an interesting case that you have given some details of, and I think it will be really helpful for us to talk about this, to tease out some of the details of it. Mm-hmm. Do you want to briefly outline the case so that we can understand what it was you were talking about? It's something to do with really around communication and ethics and end-of-life decision-making, I think. But if you can tell us a little bit more about the case, and then we'll discuss it a little bit.
Yeah, okay, yeah, that's fine. So during our work in India, so one of the roles that we have to play as a palliative care consultant or the team is actually to get involved with the multidisciplinary care conferences or in situations where there's some sort of ethical dilemma in decision-making or goals of care discussions. And we get invited to review such patients. So one particular patient was an 80-year-old lady, admitted to emergency department, unresponsive, but with a background history of frailty and old age and being bedridden. And but she didn't have any sort of any other medical comorbidities. And then during the previous hospital admission, I understand from the history that there was a do not resuscitate order, which was discussed in the previous admission, but then there was no follow-up, there was no referral to community palliative care service and things like that. And she unfortunately suffered a cardiac arrest in the emergency department. The family where the daughter was there who insisted that CPR should be started, and the patient was intubated and ventilated, and then she was transferred to the ICU. And she was there for about 2 weeks. And by the time the consultation to the palliative care team was done, it was about 2 weeks since admission when there was any sort of no signs of neurological recovery. Kidneys had started to fail, she was anuric, she was hypotensive, and there wasn't any sort of, any meaningful physiological function. So that was the case discussed to us. And then one thing that we had to mention the history was the daughter, who was the next of kin, had a legal background. I think she was a retired district judge, and she was a sole caregiver. So that was a bit of a challenge that the entire team was facing. A tricky case where a very frail lady was brought into the emergency department with a cardiac arrest, and she was resuscitated, and you were called and asked for advice 2 weeks after admission, and she had sort of multi-organ failure, kind of no real signs that she was going to recover, but she was still on life support, and it was really a matter of having this discussion with her daughter. So can you tell us a little bit about that discussion and how that went? Okay. So I think initially what happened was, so obviously, even though she had a discussion of do not resuscitate prior to the admission, it looks like the doctor insisted on giving CPR, and that's how the mom was resuscitated. So obviously got a cardiac output and was continued to the ventilator. So first protest we made was probably to make sure that, we had a new DNA CPR or do not resuscitate order signed, because we've agreed that if there's a further cardiac arrest, we wouldn't be resuscitating the mom, which the doctor agreed, and that was signed. And she was symptomatic even on the ventilator. So we started syringe drive with morphine and midazolam to help with the symptom control. But we continued the mechanical ventilation. The doctor also expressed a strong religious belief that she equated withdrawing the ventilator support was against the will of God, because she believed that, God created all these facilities and modern medical facilities was actually part of that. So we have to use it. This is what her saver. So that's the reason mechanical ventilation was continued. So that was a significant challenge. It was ethical and a practical challenge. Now, according to the current Indian guidelines for end-of-life care in the intensive care settings, we can make the decision to withdraw or withhold life-sustaining treatment after you complete a life support limitation form, which is signed by both the treating team and the patient's family. It is, there are guidelines for that. So we tried to explore her thoughts about that. Also, there were another ethical challenge that as physicians or clinicians we faced was that the principle of justice, where this ventilator that's been used for technically a sort of dying patient could be used for some other patient because who has a realistic chance of recovery or who needs it more. So that also came into play at that time.
Can you just, Sunitha, in that setting, how many ventilators were there? How is it a massive hospital or a smaller hospital?
It is a massive hospital, so it wasn't an issue at that time. So this particular hospital has, I think, more than 3 or 4 intensive care units, and each intensive care unit does have, at least 10 or 15 beds. So it wasn't an issue at that time. It could have been an issue in situations like COVID and things like that, where the use of ventilator would be, but still the principle remains there. So
yes,
that is one thing to consider.
Yeah, no, for sure. And you mentioned, interestingly, that she had signed a do not resuscitate order in a previous admission, or she'd had a discussion. Had the patient themselves signed this do not resuscitate order?
No, I think it probably was one of the family members. I'm not sure whether this particular doctor or somebody else. Usually in Indian context, that's one learning I had from the case was we don't have these conversations with the patient. It's usually with the family members, and I don't think the form goes with the form. Unlike UK, the form doesn't go with the patient to their home. It's actually just kept as record in the hospital. So even if that discussions happened, if patient community, they still end up coming back in because the system is not that developed to prevent it a hospital admission. But then the one thing that could have benefited was introducing a palliative care service. There are pockets of good palliative care service in the community, which probably could have, prevented a further admission if she was being nursed at home and things like that. But again, the legality of the forms don't travel with the patient and all those things are there.
Yes. So you're obviously now working in a system in the UK where it would be expected to discuss a do not resuscitate order directly with the patient. And then there in India, it was a situation where it's only discussed with the family. Do you have any reflection on that contrast?
Yeah. So it's a very, very interesting contrast between the two settings. Here, if you work in UK, we know that patient autonomy is a priority. You have the consent of the patient before you even have a conversation with the family. The discussions happen with the patient. Unless the patient doesn't have capacity, then we have to do a mental capacity form to say that the patient doesn't have a capacity. So you make a best interest decision, and then you discuss with the next of kin. But unfortunately, in India, it's one of those things where you try to sort of, it's like a protective thing for the patients in the sense that you don't want them to be upset having this conversation. So the family usually becomes a decision maker, and all such discussions are unfortunately not made with the patient, which I believe, if it's a competent patient who can make decision, then I think if this particular lady, even if she was bedridden, she was compos mentis in the previous admission, she clearly would have had a say in the fact that I don't want to be bedridden, and be content to ventilator. I'd rather go. I'm sure she would have a say if she was involved in the discussion. But unfortunately, we actually don't give our patients that opportunity to make a call such that, it's just the way the culture works, and it's just the way you protect your family members from such discussions. Yeah.
Do you think there's any role for that? That protection of people, or do you think it's really gatekeeping by family members? Do you think there is a way in which it can be a positive thing to, because, obviously families feel, presumably in India, that that's the right thing to do. And I think in other places that would probably be more typical.
I have had lots of discussions with people who, from the cultural background, even it's not just India, I'm told it's Asian culture. And especially cancer diagnosis, if one hears a cancer diagnosis, there's a sense that you lose your hope and, you don't tend to go for active treatment, or you become very, in shock and things like that. And somebody quoted to me, and again, I haven't checked the reference yet, literature, but saying that patients do better if they don't know about the diagnosis in a cultural context where there's a big family supporting them, and they actually do better because they hang on to the positivity and things like that. I haven't checked evidence myself, but that's what people seems to say because
interesting.
Yeah, it's an anecdotal way of saying, isn't it? Yeah, but when you pose a question as to if you were the person who has the diagnosis and would you want to be told, invariably the answer I get to anyone I ask the question is yes, I want to be told. So that is where we differ in how we care for our parents.
Yes,
and how
it's a little bit hypocritical, isn't it? Yeah. But I think it's not uncommon for that to happen. I would say also in some of the African countries that I are familiar with. So I think it's perhaps not just in India, but maybe more widespread. And it's it brings an interesting challenge, doesn't it? But you were able to then have a conversation with the daughter, and that you were able to move things forward a little bit about the care of her mother. Can you tell us about that?
Yeah. So I ended up having sort of daily review of the whole situation and daily speaking to the daughter. And I tried to find out what exactly her fears were, what exactly her thoughts were, and also discussed about trying to think about what her mother would want in situations. So some of the situations that I have seen is basically us, in a selfish way, want to see our parents alive, even though they don't have a quality of life. It's just keeping them alive. So sometimes you feel you want somebody to be alive just for the sake of you. So my conversations went on in that and tried to focus what her thoughts were about that. And I also discussed things like, I think again, culturally and religiously, there are some people, it's very important for them to be present at the time of mother's death, so of a parent's death or whatever, because you want to be in the room. So, and that is considered very important because I've heard people say, like, you've got 4 children and only one was lucky enough to be there when your parent died and others weren't. So that's another conversation. So I sort of asked her things like that, because if she was in intensive care, you won't be able to do that. Suppose because you've made a discussion of in a note for resuscitation, if her heart stops, we're not going to resuscitate her. So there is a possibility, even we can't to the ventilator, you can still have a cardiac arrest, isn't it? So, but because she's on a ventilator and connected to in the intensive care, she couldn't spend time with her mother. So that was one thing I reminded her, and also discuss the dignity of the current situation. So you'd end up having your mom die on a ventilator alone with strangers around her. The other option was so one of the work that we were doing in such patients were actually trying to extubate them. So we all know that even if you extubate them, they might not immediately die. They might have some hours, and some people actually have few days before they actually die if they take some spontaneous death. So then we do have we had a ward for such patients. It's like a step down from ICU, and it's with managed by palliative care team. So I encouraged that I would be able to move her to that ward, connecting to oxygen, and then she could spend time with her mother. And that was something that we considered. Initially, that the doctor actually felt it was traumatic to be in the same room as a dying mother. These are things that you don't actually think about, isn't it? Yeah. And then that brought distress to her, and then obviously I spoke to her later. And then later on, after 24 hours, the doctor contacted me back to say that she has thought about it a lot, and then she didn't want her mother to lie in the ICU alone, and she wanted her mother to be surrounded by family during the final hours. So then we decided that, because she did have spontaneous breaths, as I told before, we could connect to a T-piece which can deliver oxygen, because I think she already had a tracheostomy, because of prolonged ventilation. So we disconnected from the ventilator, connected her T-piece, and then we moved her out the ICU. And
so
then,
how many times, if you don't mind me asking, how many episodes of communication did you have with her? Was it once? Was it twice? Was it 6 times? Roughly, because you said you were meeting on a daily basis, so it's pretty like time intensive. This
it was So I think it probably went over a week. I think since after the referral. We work Monday to Saturday in India, so only Sunday is a not working day for us. So I ended up seeing her every day. And the thing that is again different from, here is we give a personal mobile number to patients and family. They expect that. So I think I probably did give my number to her, and daughter did call me.
In India, you'd give her your number.
Oh, yeah, in India. Exactly. Yeah.
Gosh,
This
yes.
is different. You don't have to, but I think most of the doctors do. And so we end up doing it ourselves because otherwise they won't, it's sort of, they can't talk to anybody else. We would, that sort of thing. So I think I ended up giving my number to her, and, she contacted me, and probably talked to her over the phone also. And then within a week's time, a decision was made to move her out of, and the medical team was very, very grateful for our support because they were not getting anywhere with her.
Yeah,
sure.
Yes. And I mean, do you mind me asking about how her healthcare in this situation was being financed? Because sometimes, costs of care can influence decisions. I mean, you mentioned obviously the issue of justice in terms of access to the ventilator, but I think there's also, for some families, obviously, something like an ICU, might not be possible because they couldn't afford it. Obviously, it sounds like this woman, at least the daughter, had some finances. But do you think finance was relevant in this case at all?
Very important. And in this case, as you rightly said, I don't think they had any financial issues because this case was in a private hospital. So they will have to pay for whatever care her mom was getting. If you are in intensive care, the payment you have to make per day would be understandably much higher than in a general ward.
Yes.
But that didn't come into picture because I think they were financially well off. So that wasn't at all. So they were able to manage that. If it was not, it's probably, we will be having this conversation because the patient family would be able to afford it. And that is a sad situation again. And the sad situation where it's the justice. So if another scenario, if the patient doesn't have money, even the patients that we could probably save by a ventilator, unfortunately can't go in a ventilator because they can't afford. And some hospitals and this particular hospital do have incentives for poor patients, so they have to prove that if they really don't have any financial background, there's some paperwork they can fill, and the hospital does take some charges away. There are rules to do that. Majority of the patients is paid out of pocket, and this family could afford it, but you could have another family who wouldn't be able to afford that.
Yes. And at the end of this, and I'm going to talk to you a little bit about learning points in a minute, but how do you feel that the daughter kind of left this situation? I mean, presumably her mother died on your palliative care ward, and then, that was kind of the end of the care episode with the daughter. How do you reflect on that now, the kind of journey that the daughter was on and then, had to go through her mother's death and so on?
Yeah, it's interesting because it brings to the board be able to provide, and unfortunately there is a developed event support team. I mean, I remember that doctor called me personally later to thank me for the work I had done, and then I think that's it. And I think I understand it would have been better more for the follow-up calls or any support from the team that is able to give that, because there must be a reason, and there was a reason definitely that she wanted to her mother, and how is she going to cope after that, isn't it? And things like if she believed that what she was doing was God's will, in the sense that you have to keep the mother alive. If she made a decision against that, then how is she going to cope with that? So all these things probably could be followed up. If there was a bereavement, but. I think my interaction with that family ended with that one phone call where she called me and said, "Thank you for what I've done."
Yes.
But I think there needs to be a team to support them.
But I mean, it's interesting that she did that because obviously she didn't have to do that. And that in itself is an indicator that she had kind of come to terms with or made some sort of peace with some of those barriers, if you like, that she was putting up in the first place, because obviously I'm still feeling that I wouldn't have phoned you to say thank you. Do you, I mean, you obviously spent a lot of time building this relative and giving her a daily conversation, those kind of able to really express some concerns, which, if I get you right, were about not wanting her mum to die alone on the ICU. That seemed to be important. So even though initially she was talking about, God gave her technology to support her mum to stay alive and that therefore it should be used, but then she did seem to be able to talk about her mum's death. Was it difficult to get her to that point to talk about death, or is it acceptable to talk about, do you feel?
Initially, it was difficult because the reason she was keeping her mom in the ventilator was she wasn't picturing her dying, isn't it? But
Right.
as days, in a couple of days went by, and we had conversations, and I think she was able to that whatever she was saying, her mom was not alive; it was just the machines working for her.
Right.
So she sort of accepted and felt that whatever she was doing was probably not what her mom would have wanted.
Right.
And I think giving them opportunity to think it that way, as in what it's want for my mother, it's what my mother want for herself, is probably
Yeah.
the key to actually to starting those conversations. And then later on, yeah, she realized maybe that's what she should be doing. Yeah.
Mm, mm. And can I ask you a little bit about your response in that situation? What does it take a lot, or have you done it so much now that you just kind of,
hmm
this is what I do, this is my job, I know that I can do this well, so I'll do it. How does it affect you as a professional? Or
I
does it
think
affect
all
you as a professional? Yeah.
Yeah, I'd be lying if I said no because affect us and it stays on, isn't it? This is
Mm,
probably more than 6 or 7 years now, and still seem to think about that and
mm,
sort of picture the daughter in the same room
mm.
and obviously we might even take it personally. So it's not easy to have these discussions, but actually. At the end of the day, what I think is, if I don't do it, then there's nobody else to do it. So it's one of
Yes.
those things where our team, has to do a lot of cases like that, and it's important that all teams do it. This what I believe is death is part of the living sentence, and it's
Mm,
part of this conversations that should be have earlier on rather than
mm,
we should be talking about dying is what I think.
mm,
And it's difficult not to get involved personally, but at the end of the day, I think we have to it should, and hopefully
mm,
do the right thing for the patient and the family.
mm. Yeah, yeah. Do you think what are the kind of, do you think, learning points? I mean, perhaps not so much for yourself, but for other people in situations, is there anything that you feel you've taken away from this that, or that you'd like to share with other people in terms of learning points?
Yeah, I think the learning point from this is probably one of the main thing, and which can be applied to both any context of palliative care is the early involvement, having the early discussions, which should be timely. Now, the one thing to remember about this particular patient is, she's a non-cancer diagnosis. So, as we all know from evidence, palliative care involvement in the globally is more for cancer rather than non-cancer because of the
Mm,
specialty. But it's important for us to realize, even for non-cancer conditions, death is always a natural. It's part of your the living, and it's a natural process. So they will reach that point anyway. So it's good to identify and to have these conversations around, have goals of care discussions. What always know what the patient actually wants when they're
mm,
engineers. It's important for us to do that.
mm,
And then if you talk about India, it's a cultural context, India, where it's and the other thing that the listeners in the other background which think is that culture travels. So you could
mm,
have a scenario like this in a developed country because
mm,
India is the largest diaspora in the world, I think. So wherever you go to Australia, to United Kingdom, States, you would probably meet an Indian family of a similar scenario. And
mm,
it's important for the physicians working at different contexts to understand where it's coming from because the context is different. The value of life, the way you see life is different. So that's the reason you would see patients like that, and it's important to understand that, but also to approach in a different way, but always discussions. And obviously, the role of religion in the decision making is very, very important. India is a strongly religious country. What it could be either be Hindu, Christian, or Muslim, you all religion in the country, and so that's very, very
mm,
important in their decision makings. And again, that can travel wherever they are.
mm. Yes. No, that is very true, isn't it? That
Mm,
yeah, we live in a global village, so
mm,
certainly
mm,
meeting people from different religious language backgrounds, all these things are very important. And I think you kind of touched on another that maybe we need to revisit the
sure.
topic of advanced care planning,
Yeah.
and how that might work out. But that's probably for another day.
Mhm.
If you look back at this case, I mean, I don't think there is. I'm not saying anything that you should have done differently,
Mhm.
but you feel could have been done differently if it was happening again.
Uh-huh.
That, I mean, you sort of mentioned about timely referral, and you were
Yeah.
involved 2 weeks after admission. Do you think you could have been involved earlier? you think palliative care should have been involved earlier?
Again, it's not easy to do that. But I'm in my current job. I'm doing a lot of work in getting patients department and seeing patients there. And one of the work I'm doing is a joint work with a team in India. In the intervention palliative care, not in the same place where this case was, but in different state. But that is also happening. So I think there is a role of having daily reviews or even being called directly to the immense department. And in this particular scenario, whether you could have, hashed about DNS CPR in that current admission and maybe avoided the patient going into ventilator in the first place is probably one we could have done. But I think there's a lot of work to do.
Yes. It's a lot to expect, isn't it, from a family member to...
Sure. Yeah.
Because I think this patient or the relative sort of demonstrates the importance of building that relationship over time so that she could trust you and then disclose these various elements, and you were then able to discuss the reality of death and dying and how that might take place. So to imagine that could all happen in one sitting is probably a bit tricky, but obviously if people are ready for that, then definitely trying to avoid admission would save quite a lot of obviously costs, but also save stress and other things for the family if they can take those decisions. So that's great. Is there anything else that you would like to add before we finish?
No, I think we've covered everything. Thank you very much for the opportunity to talk about this case.
No, it's great. I think it's been really interesting and very that I think not everybody will work in situations with ICU, but I think this issue of the treatment happens in a whole variety of settings, doesn't it? Not necessarily only ICU, but high dependency or on a variety of maybe dialysis or other kinds of treatment. So it's relevant for lots of different settings. And I think been very interesting. And we could probably get into some of the maybe advanced care planning and or communication. How do we communicate? We can probably do that in another episode.
Yeah. That's true.
Thank you very much for your time.
Brilliant.
And
thank you.
Thanks. Okay. Palliative care matters because palliative care isn't just a specialty. It's something we all do. Subscribe wherever you get your podcasts.